Hi, my name is Binod Dhakal and I'm Associate Professor of Medicine at Medical College of Wisconsin. At this EHA meeting, I'm presenting an oral abstract on the phase 1 study of CAR-T ddBCMA in patients with relapsed refractory multiple myeloma, results from at least 1 year follow-up in all patients. CAR-T ddBCMA has been named anitocabtagene autoleucel or anitocel. This is a unique CAR-T, a novel CAR-T because the binding domain is a synthetic binding domain called a D domain. D domains are triple alpha helical structure with a hydrophobic core, and this domain allows high transduction efficiency and high surface density on the surface of a CAR cell. Additionally, there is a low risk of tonic signaling because of the small size and lack of side chains. We tested this anitocel in patients in a dose escalation first in human phase 1 study. 2 dose levels were tested, dose level 1 and dose level 2, and based on the early data, the decision was made to expand dose level 1, which is a median dose of 115 million cells. The patients who were included had a triple class exposure, means exposed to 3 different classes of drugs and had to have 3 different lines of therapy, or they need to be triple class refractory. In the baseline characteristics, the median age was 66 years, the median prior lines of therapy was 4, and 100% of the patients were triple class refractory patients. In addition, we defined what we call as a high risk prognostic feature, defined as bone marrow plasma cells of more than 60%, ISS stage 3 disease, and extramedullary disease. 63% of patients had at least one of those features. More importantly, the true extramedullary disease was present in 34% of the patients because the study allowed patients with non-measurable disease but with measurable plasmacytoma to be included. The overall response rate was 100% in this total patient population. The complete response rates and better was 76%, and 92% of the patients achieved very good partial response rates and better. The most impressive is the complete response rates and better was similar in patients with high risk prognostic feature, extramedullary disease, high risk cytogenetics with and without 1q gain, and age more than 65 years. At a median follow-up of 26.5 months, the median PFS was not reached with anitocel. The median PFS in patients with complete response and better was also not reached. The 24-month PFS rate was 56%. There could be further evolution in the curve with additional follow-up, but the median PFS is likely to be greater than 2 years in these very difficult to treat patients. In the extramedullary disease, at a follow-up of 33 months, the median PFS was not reached, and that is quite impressive. In 24-month PFS was more than 55% in the overall patient population and different subgroups, including the high-risk subgroups, and that is perhaps the highest PFS rates reported at 24 months in these difficult to treat patients. In terms of safety, there are no new safety signals. The grades 3 and CRS was not present in patient with dose level 1, and there was only 1 case of grade 3 ICANS. There were no delayed neurotoxicities, there were no Parkinsonian-like syndromes, there were no cranial nerve palsies, and no Guillain-Barré syndrome. So in conclusion, anitocel is a novel CAR-T construct based on its novel binding domain and with the attributes of high transduction efficiency and high surface expression of the CAR. These attributes have enabled a clinical activity, what we saw in phase 1 with 100% response rate, and 76% of the patients achieved complete response rates and better. At 26.5 month follow-up, the median PFS was not reached in the entire patient population and also in the high-risk subgroups. In terms of safety, this efficacy is paired with a manageable safety profile with low risk of high-grade CRS ICANS and no delayed neurotoxicities. This product is being evaluated right now in a single phase 2 pivotal study in patients with 3 or more prior lines of therapy and is undergoing enrolling the patients. Thank you.